Myself as well. My name is Rebecca Brynjulson. I'm a pharmacist and a faculty member at North Dakota State University in the School of Pharmacy. And my area of interest and specialty is ambulatory care and geriatrics. And so I have a board certification in both of those areas. In our School of Pharmacy, I teach primarily in our introductory pharmacy practice experience coursework, and I also teach in our pharmacotherapy capstone course, which is a problem-solving course for students before they begin their clinicals and rotations. My practice experience in the past, although not currently, has been working with the VA and their patient population in St. Louis, Missouri was the last time that I worked in an ambulatory care clinic. I also have done a lot of volunteering and working with assisted living and independent living individuals in our community here in Fargo. And so those are kind of my background and where I'm coming from in this presentation. I do want to talk today about adverse drug reactions in geriatrics. And some of the principles that I'll talk about today certainly will be expandable to other patient populations besides geriatrics, but we are going to focus on those things that really are more specific towards geriatrics as well. Our objectives for our presentation today are to define adverse drug reactions, to identify selected risk factors for adverse drug reactions in geriatric patients, to discuss the role of pharmacokinetics and pharmacodynamics in adverse drug reactions, to identify strategies to prevent adverse drug reactions, and then to actually evaluate a geriatric patient case to identify or prevent potential ADRs. And so that will definitely be a more interactive portion of our presentation today. So I will ask you for your input and your feedback and give you some of my thoughts on how I would approach different scenarios with this fictitious patient as well. First, we're going to start off with defining adverse drug reactions. So the definition that I give you is actually kind of an old definition from 2000, but it really hasn't changed much. It definitely applies to how we look at adverse drug reactions now. And it is defined as an appreciable harm or unpleasant reaction resulting from an intervention related to the use of a medicinal product, which predicts hazard from future administration and warrants prevention or specific treatment or alteration of the drug dosage regimen or withdrawal of the product. So it covers a lot of ground, to use the definition that was written by Edwards and Aronson, and they are really capturing all of the different components that could be part of an adverse drug reaction. So adverse drug reactions themselves then can be classified, and there are a number of different classification schemes that have been proposed over the years, but broadly, those classification schemes are based upon time to reaction and dose dependency of the reaction, and then whether the reaction itself is predictable or unpredictable. So I always like to remind people that medication use always comes with risk. There is no perfectly safe medication. And whenever a patient uses a medication, they do assume a certain amount of risk that they may have an adverse drug reaction. And we try to use the knowledge that we have about these medications and the dosing of these medications and the use in populations that have been studied to minimize those drug interactions. So there are some adverse drug reactions that really are predictable. So for example, a medication that we use commonly, hydrochlorothiazide. So when we look at hydrochlorothiazide, we generally see doses of 12.5 to 25 milligrams daily for hydrochlorothiazide. You can go up to 50 milligrams a day. That's within the prescribing recommendations. But we do know that an increase from 25 milligrams a day to 50 milligrams a day does not necessarily improve blood pressure control, but really does increase the risk of adverse effects due to electrolyte abnormalities. So it's very uncommon to see 50 milligrams a day of hydrochlorothiazide used. So that's an example of something that we can predict that is dose dependent that we may see in a patient population. Another example of adverse drug reactions being based on time to reaction, whenever we receive an immunization, often we are asked to wait for a period of time after that immunization is administered. So immunizations are also medications, and we know that if we're going to have an immediate reaction to that immunization, that we're generally going to have it in a pretty short time period after administration. So that would be monitoring for an adverse reaction that's based upon time. We also know that we still collect information about adverse drug reactions that happen after 2 to 3 days after administration of a vaccine. And so that would be, again, an example of something that there might be an adverse drug reaction that's more time dependent. It might take several days for you to see the reaction, but we still want to be aware that it may be caused by a medication that's recently been administered or started. There are other adverse drug reactions that are idiosyncratic. We don't know exactly why they're caused or why they occur in a certain time frame, but nonetheless, they still can occur. And those tend to be more rare. And we would know medications that were associated with that. That would often be something that we would be counseling patients about, or we would be talking to patients about if it's a significant adverse drug reaction. So again, adverse drug reactions as a whole are broadly classified based upon time to reaction, dose dependency, and predictability of the reaction itself. There are definitely selected risk factors for adverse drug reactions in geriatric patients. We do know in geriatric patients that there are specific medication classes that have been identified as high risk for those patients. So we use tools and information like the 2019 AGS-BEERS criteria to help inform us of what medications are high risk and should cause us to pause in use in this patient population. There are 2 articles that I have cited here for you today that talk about medications that have increased risk for adverse drug reactions. And some commonalities between these 2 articles would be medications that are anticoagulants, medications used to treat diabetes, and opioids. So those are some classes of medications that we have a lot of evidence, we have a lot of research that has shown us that those tend to be higher risk. Now there's a variety of reasons why they're higher risk, and we'll talk about some of those as we get to our patient case and also some of the later information that we have as well. We also have to remember and recognize that risk can be attributed to the impact of aging on medication pharmacokinetics and pharmacodynamics. So the process of aging in and of itself creates changes in the body and how our body reacts to medications. So it would not be unreasonable to think that a geriatric patient may respond differently to one type of medication than a younger patient may respond to that same medication. And there are definitely some differences. We can talk a little bit about those differences now in relation to pharmacokinetics. So when it comes to absorption, there's not a lot that changes with absorption, I don't think, when it comes to geriatric medication use. Some things, though, that you may want to consider are just natural changes to the GI tract and thinking about how those medications are absorbed from the GI tract. And so it could be that patients may have conditions that would predispose them to decreased absorption through their GI tract. There also is a decrease in active transport. So some things like calcium, iron, vitamin B12 are not absorbed as well in geriatric patients as they are in other patient populations. When we look at distribution, that's how the medication is distributed throughout the body. And we're going to see that there are changes in volume of distribution depending upon whether a medication is water soluble or whether it's fat soluble. This distribution also depends a bit on blood flow, which affects tissue perfusion as well. So just thinking again about changes in the geriatric physiology, we can see that distribution occurs a little differently in patients who are older compared to younger patients. The next one we have is metabolism. So lots of medications are metabolized in the liver. And so we see changes to hepatic blood flow occurring in older adults. And so we see changes to the way medications are metabolized depending upon blood flow and how that metabolism happens, whether it's a first pass or second pass metabolism, protein binding, all kinds of things that are happening with the liver as well. And then finally, we see excretion, and excretion or elimination is really looking at the kidneys and renal function. And so we do see in older adults that there are changes in the way medications are, the changes in glomerular filtration, there's changes in the way medications themselves are eliminated. And so we have to take those things into account as well in trying to prevent adverse drug reactions. So pharmacokinetics can play an important role. So when we're thinking about drug interactions, as patients get older, we're also thinking about how the aging body is impacting those medications and whether dose adjustments need to be made or different agents chosen based upon a patient's pharmacokinetics. Pharmacodynamics is also something that we have to think about when it comes to geriatric patients. So pharmacodynamics have primarily focused on looking at things like maybe an increased sensitivity overall. So an example of this might be anticholinergic medications. Patients are increasingly sensitive to the effects of anticholinergic agents as they get older. So again, lots of changes with pharmacokinetics and dynamics. Those were kind of a brief overview of some changes that you can find, but there are just in general lots of changes that we see. So strategies to prevent adverse drug reactions in geriatric patients. In addition to considering drug interactions, the AGS-Beers criteria and the geriatric 4Ms consider the impact of pharmacokinetics and dynamics on medication choices. So we want to think about dose adjustments, product selection. Pharmacist is a really great resource on the healthcare team for helping to identify and manage those medication-related problems. And then overall, there are goals of therapy for treatment and or if adjustments are appropriate based on age. So we do want to think about those things as well. All right, well, with that, we are going to hop into looking at a case study and trying to identify some pearls or some key things that you might think about or take away from looking at this case study and use in your own practices related to identifying and preventing ADRs. So we're going to start off with just an overview. Our patient that we have that we'll be discussing today is an 80-year-old female who presents to your clinic to establish care. She was last seen by a provider 5 months ago and diagnosed with urinary incontinence, stress incontinence. And today she reports dry mouth and occasional dizziness when she stands or when it's been a while since she's eaten. As a part of her visit today, her medications are reviewed for appropriateness. And we'll go through some of those things. But before we get started, what are some initial thoughts that you have related to the information I've just told you? And you can either feel free to chime in with your microphone or also to type in the chat box. Oops, I'm going to just pull this over. Sorry, everyone. So blood pressure and meds, I see, and that's a great place to start, Lori, you're right. So definitely checking her blood pressure, since she also comments it's been a while since she's eaten. I'd be curious at this point to know if she maybe has diabetes and maybe there are some of her medications that would be good. Dehydration, yes, Jane, that's definitely something we would want to check as well. As a pharmacist, one of the things I always think about are adverse effects. If someone tells me they're having dry mouth, I always think, can a medication be causing that? Or dizziness, can a medication be causing that? And so even though we might think that pharmacy hopes people will be on medications because that's what we do, or pharmacy, really my goal as a pharmacist would be to make sure a patient is on as few medications as they need to take care of the conditions they have. I would not want to be contributing to adverse effects or to having them take more than they actually need, just like That would be the goal for all of us when all is said and done. So definitely we want to review her medications. We also want to be sure that if we have the ability to decrease or eliminate medication side effects, that we do that. We want to avoid prescribing cascades. And so a prescribing cascade would be an event where a medication or an agent is added to take care of a side effect that was caused by another medication. So we always want to try to avoid those prescribing cascades. All right. So the next thing I'm going to give you is her past medical history. So she has hypothyroidism, which was diagnosed in April 1999, hypertension, which was diagnosed in May 2002, dyslipidemia, which was diagnosed in May 2002, diabetes, which was diagnosed in May 2016, osteoporosis in June 2015, and urinary incontinence, stress incontinence 5 months ago. So what are your thoughts about those? Anything that you can think about, and we will go through this discussion and guide it a little bit as well. So if you have any comments to make, you're welcome to add those in. All right. Okay, so blood sugar readings. Yep, so we'd want to look at blood sugar readings. The thing that I think about when it comes to past medical history as well, and I'll just kind of start this discussion, and we can maybe head down the list and think about this as a group as well. But when I'm reviewing a patient's medical history, it can be helpful for me as a pharmacist to know what the goals of therapy are for the patient. Sometimes there are multiple recommendations for goals of therapy, multiple potential recommendations, and those recommendations are going to be made based upon a provider-patient discussion of risk and benefit and what would be most appropriate for that patient. And so if I'm reviewing a patient's medications and I'm looking to see if their medications are safe and effective, it's helpful for me to consider overall goals of therapy for the treatment. And if there are adjustments to the medications that can be made or are appropriate based upon age. That is one strategy that we have for preventing adverse drug reactions in geriatric patients. And so that's somewhere that I like to start as well. So having that in mind, let's try to think about some specific goals of therapy for this patient. Hypothyroidism, there's not a lot that we have for goals of therapy that would be changing or adjusting based upon age. So I'm going to hop over that one for now, but I will touch on hypertension. So this patient has almost a 20-year history of hypertension and is a diabetic patient. So what are some possible blood pressure goals that we may have for this patient? If you guys would like to chat, or a few of you would like to type it in the chat, that would be a great way for us to share with one another.
This is Jane.
Hi, Jane.
And so as people get older, their blood pressure actually needs to be a little bit on the higher side versus like 118, 100, because they will get dizzy and stuff if it's too low. They need the circulation. So you don't want to have a goal of like 120 over 80. Probably for the elderly.
Right. So I think you touched on another pharmacodynamic reaction that we see. Older patients are naturally predisposed to having orthostatic hypotension more commonly than younger patients. So that we'll definitely be looking at this patient's blood pressure and looking at whether they need to have a decrease in their dose. I think that if we look at clinical practice guidelines and if we look at what is recommended at this point, we might see a variety of blood pressure goals. You might see less than 130 over 80 for a patient that has higher ASCVD risk. You also might see less than 140 over 90 for a patient who has a lower ASCVD risk, looking at 2021 standards for diabetes care, for example. But you might also see a higher goal, and there is a little bit of evidence to support a higher goal, but a lot of it depends upon tenure risk and the patient's life expectancy, this patient's symptoms, and whether they are whether they're able to handle a lower blood pressure goal. Just like Jane said, some patients are going to experience adverse effects if they're having orthostatic hypotension. We don't want them to be falling. And so we may not be able to have as stringent of a goal as we would hope for those patients. But we do know that blood pressure and controlling blood pressure prevents microvascular complications and macrovascular complications. So we do still want to control their blood pressure to the best of our ability. All right. Yes, Lori, thank you for your comment. Lori commented about adjusting dosage to prevent orthostatics with mobility. We also can take a moment to stop and look at dyslipidemia. For this patient, she was diagnosed in May 2002. And since May 2002, there have been a lot of changes to what the recommendations are for primary prevention and how we approach treating patients for primary and secondary prevention. We don't see that this patient has clinical ASCVD based upon their past medical history that we see here. There's no clear goal recommendation for this patient, although the patient also has diabetes. Our current US cholesterol practice guidelines provide guidance for individuals between the age of 40 and 75 years old, and with age over 75 based on clinical assessment and risk discussions. So we've got that to factor in as well. It doesn't mean that we shouldn't use statins in patients who are over 75, but it does, there is a lack of evidence at this point to say one way or another whether we should continue statins for extended periods of time. The only patient population over the age of 75 where they have shown, really one of the only populations where they've shown benefit for discontinuing statin would be using discontinuing use in palliative care. The rest of the times, it would be a patient-provider discussion. So we would want to consider other things that are going on for this patient. So their family history, they do have diabetes. We don't know their family history. We would want to consider life expectancy, but a statin seems reasonable in this patient. And a dose of statin we would want to assess to determine if it seems reasonable as well. And the patient does have a few predisposing factors, but definitely a moderate dose statin seems to be reasonable for this patient. So we want to keep that in mind as well. Osteoporosis is something that we would look at and consider in this patient as well. So we would want to figure out, we don't know necessarily, if we want to know if this patient's on a bisphosphonate, and if she is on one, how long she's been on it for. We also would need to be able to reassess if this patient is low, moderate, or high risk for a fracture so that we could determine if we should be persisting in treating this patient at this time or take a short holiday. So those are things we'd want to consider. And then diabetes. That's another one where we have some goals of therapy. What do you think about treatment of diabetes in elderly patients and A1C goals specifically? I'll let some folks add to the chat if they'd like or speak out on their microphones. Is it always necessary for older individuals to have an A1C less than 6.5%? I'll ask that as a question first. Maybe I can get a few people to chime in. No, I see usually comfortable around 8. No. Is it reasonable for an A1C to be less than 7%? That's more reasonable, I think, than less than, yes, Natasha, it depends on the patient. It would be more reasonable to see an A1C of less than 7% compared to less than 6.5% for an elderly patient, for sure. There is some evidence, and I'll read to you what the 2021 Standards in Diabetes Care state, so that you have a good frame of reference for what they have for the goals of older adults. This is directly from their statement. Older adults who are otherwise healthy with few coexisting chronic diseases and intact cognitive function and functional status should have lower glycemic goals, such as A1C less than 7 to 7.5%, while those with multiple coexisting chronic illnesses, cognitive impairment, or functional dependence should have less stringent glycemic goals, such as A1C 8 to 8.5%. So again, it really does depend upon the patient. And when you look at multiple coexisting chronic illnesses, I think that part of the intent with that statement would be illnesses that are limiting life expectancy as well. You know, looking at, again, control of blood glucose, like control of hypertension can lead to less incidence of having a stroke or MI, these major macrovascular events. But we also want to balance that prevention with the risk of hypoglycemia or risk of fall as well. So we're trying to maximize the patient's treatment in those areas. But it wouldn't be unreasonable for patients to consider some slightly higher goals depending upon the patient specifically, like Natasha said. All right, so let's look at a little bit more information now that we've kind of framed what might be reasonable for a geriatric patient in looking at goals of therapy. So here are some vital signs and lab values, along with a list of the patient's current medications. So for those of you who are worried about orthostatic hypotension, does this patient have orthostatic hypotension? So I see not on this measure. So we have two values here. So orthostatic hypotension would be, we could justify it or classify it based on one or two ways. We can look at a change in greater than 20 millimeters mercury systolic, or a change in greater than 10 millimeters mercury diastolic. If we look at the diastolic, we would see that it does meet the criteria for orthostatic hypotension based upon the diastolic reading, not necessarily though yet on the systolic reading. So that's something that we'd want to keep in mind as we're making adjustments for this patient's blood pressure. In general, their blood pressure looks pretty good. It's not really low, but it's also not elevated. So that's something to keep in mind as well. How about the Chem7? Is there anything on there that seems unusual to you or overly surprising? So I don't think there's anything that's overly surprising. If we were looking for levels that were out of the normal range, we would see that the glucose is slightly elevated. Also not unexpected for a patient who has diabetes to have a glucose that's slightly elevated. The serum creatinine is slightly elevated as well outside of the normal range, but again, not uncommon for an older individual to have a slightly elevated serum creatinine. Again, when we look at serum creatinine, looking at trends is important. So, you know, if a patient always runs around 1.2, 1.3, that would be very normal for them. If this patient normally is a lot lower or normally is a lot higher, we might see this as abnormal in comparison to previous results. But serum creatinine of 1.3 is not atypical per se. We see that the A1C is 6.8%, so that's good by all measures, but maybe not good for this patient, depending upon if we feel like we find other things that cause us to address her medications for diabetes. And then the TSH looks good today. There are some labs we don't have. So, you know, we're missing information here related to the patient's fracture risk. We talked about osteoporosis. We can't really make a determination here on that. We're missing lipid levels. So we don't really know how that atorvastatin 40 milligrams that she's on that we can see in her current medication list, how that's doing for the patient. And then we also don't have measures of liver function for this patient in relation to some of the medications they're using. But again, we may not necessarily look for those or order those right away without having a reason to do that. And so we'll look at her current medications, and then we can make some more determinations after that. All right. So the other thing that pharmacists routinely do when we are evaluating patients and medications and safety for medications is we calculate a creatinine clearance. And so some of you may or may not be familiar with that creatinine clearance calculation or an estimation of renal function. We know that many medications are dosed and renally dose adjusted based upon creatinine clearance, which is again an estimate of renal function. And that can be important for us to calculate for all individuals, especially for elderly patients in reducing potential ADRs. So we want to always be able to look at that and to think about our patients' medications and their renal function and whether they need to be dose adjusted. And that's something really that's ongoing. A patient's renal function can fluctuate. And we even know that there are some medications that are held for certain procedures because it's expected that the renal function may fluctuate a little bit with those procedures. And so they might be held and then restarted. Other medications are dose adjusted based off the eGFR, so the estimated glomerular filtration rate. And that is, that's another thing that we would look at. So it's again, another measure of renal function. So a lot of the dose adjustments, it was, the determinations of safety were based upon the studies that were done and the dose adjustments that were made during those studies as well. So sometimes when you see whether a medication is dose adjusted based on creatinine clearance or eGFR, it's based upon what the research that got that medication approved, what they used to make their determinations. So that's why we don't necessarily see a uniform measurement across the way. There are also some variations in the way creatinine clearance is calculated. And so different calculators might give you different responses based upon whether they use actual body weight, ideal body weight, adjusted body weight, those types of things. And there are different situations where you may consider using different weights. But again, overall, important to remember that creatinine clearance is an estimate of renal function. So it's not a perfect number that we use, but it does help us to guide us in making decisions. So for this patient, I did calculate a creatinine clearance, and this patient's actual body weight was less than their ideal body weight. So the creatinine clearance is 31.6 mils per minute, and they had an eGFR of greater than 30 mils per minute. So that's helpful for me to know as I'm evaluating medications so that I can determine more quickly if something needs to be changed. So with that, I think we're just going to go through the medications, and I'm just going to give you some general impressions I have or some thoughts I have about these medications. They're fairly commonly used in patients. And so if you have questions, please feel free to chime in, but I'll tell you kind of my thoughts about how I would approach this patient's medications and what I would recommend for discontinuing based on this patient scenario and the limited information we have, recognizing that there's so many other factors that go into these decisions when we have real patients in front of us. So the first medication on the list is the levothyroxine. And for me, that doesn't seem to really raise any sort of red flags. I don't really have any questions about levothyroxine. There's an indication for it. She has hypothyroidism. Her TSH looks good. So I don't really see anything there that is really critical. I do think that I would encourage her to continue taking her medication in the same way that she's taking it, with some other medications that may change the change absorption of it, or however she's doing it right now. I would ask her to continue it. When patients are starting off using levothyroxine, we like them to separate that dose from other medications. But again, like we've adjusted this patient's dose based upon how she's taking it at this point, and it's in the normal range, so she should continue. The purpose for each of these, Lori, I would be happy to do that. So levothyroxine is for hypothyroidism. So that's the indication for this. And really starting with indication is a great place to start, because if there's no indication for the medication, that's a good indication that we should take it off the list if we can. The next two medications that we see on the list are hydrochlorothiazide and lisinopril. So this patient is currently experiencing orthostatic hypotension by definition with her diastolic blood pressure. And so we do want to prevent falls while controlling blood pressure to the best of our ability. So there are a couple of things that we can recommend with this. I think decreasing her antihypertensive dose would be appropriate. And this hydrochlorothiazide and lisinopril are available in a combination tablet as well. And so I think combining these two into one tablet would also be a helpful strategy for helping to decrease the pill burden overall for this patient. So I would recommend a decrease in your antihypertensives, and then antihypertensive, you might choose to start with one agent, perhaps a hydrochlorothiazide, and do 12.5 milligrams of hydrochlorothiazide and 20 milligrams of lisinopril, and then recheck her blood pressure again and make sure that's appropriate, and then consider changing to just a single pill. So if you're able to get her to a dose where she is stabilized, and then recommend a combination pill, that would be great, I think. Atorvastatin 40 milligrams, looking at this at first glance, I might not be too concerned about atorvastatin 40 milligrams. This patient is an older patient though, and this medication is being used for primary prevention, and it's technically a high intensity statin. So I don't know that we need to use a high intensity statin in this patient for to meet the guideline recommendations that we have for individuals in this situation. So we're looking at patients who have diabetes at this point, more so than those who are necessarily over or under a certain age. So I think decreasing the atorvastatin dose might be reasonable, and it might also be a good way to minimize adverse drug reactions as well. Certainly we don't need to use a high intensity. That might put the patient more at risk for myalgias. She does have a few predisposing factors for myalgias. She has metabolic disease. She also is a female, which would increase her risk for myalgia. So using the lowest possible dose, most appropriate. The next two that we have on our list are metformin, 1,000 milligrams by mouth twice daily, and glyburide, 1.25 milligrams by mouth daily. These are both medications that are used to treat diabetes. Metformin should be, or is often recommended to be used first line. And as long as the patient's eGFR is greater than 30 mils per minute, it would be appropriate for this patient to use metformin. And so her eGFR is, and so it would be appropriate to continue that. We wouldn't expect hypoglycemia to be a result of metformin use. Glyburide, on the other hand, is a sulfonylurea. And there is, according to the AGS-Beers criteria, a high risk of hypoglycemia in older adults with the use of this medication. And it is recommended to avoid this medication in this patient population. And it is a strong recommendation from the AGS-Beers criteria. So given the fact that her A1C is 6.8% today, and knowing that it would not be inappropriate for her A1C to be closer to 7, and that this is a relatively low dose of glyburide, and she's potentially experiencing some hypoglycemia. If we remember back to that first slide, sometimes when she doesn't eat, she feels a little unsteady. It would seem reasonable to discontinue the glyburide for this patient and to monitor her A1C to see how she does without the glyburide as well. So that would be my recommendation for glyburide. There are other agents that can be used if she needs to have increased control of her blood sugars, but it seems like that would be a good first step, would be to discontinue that one. The next medication that we see on her list is alendronate, and this is a medication that's used to treat osteoporosis. It's a bisphosphonate, and it should not be used in patients with a creatinine clearance less than 35 mils per minute. So she actually may be at increased risk for adverse drug reactions because her creatinine clearance is too low to use this medication safely. Now, we don't have a current assessment of her osteoporosis. We could check her, and we should check her current level of risk, or to determine whether she should be on alendronate. there is a recommendation that if a patient has been on alendronate for a period of time, that we consider a holiday from it. And this might be a perfect time to consider a holiday since it's no longer safe for her to use it in the same way. So we could check to see if a holiday would be appropriate. If she is determined to still be high risk and needs an alternative therapy, there are therapies that are alternatives that don't require renal dosing. And so that could be something that we look at. We could look at raloxifene or calcitonin. Neither of those require dose adjustments for renal function. And we do still, regardless of what we choose for this patient, we do still want to make sure that she takes calcium with vitamin D. Now, if you remember, one of the things we talked about earlier in our presentation was the decreased active transport and absorption of calcium for patients as part of absorption in our pharmacokinetics related to older individuals. And it's also good to keep in mind that as we get older, the acidity, well, always acidity in our stomach also impacts absorption. And so that's some of this too. There are various calcium salts that are available for patients to take when they're choosing calcium. Calcium carbonate is commonly used, but calcium citrate can be better absorbed in individuals who have a lower gastric pH. And so we want to be sure that we consider whether the type of calcium we're using is best too. Now, there are differences in prices and other things. And so, making sure a patient gets adequate calcium is important, but we can also even think about the salt forms that we use for different medications to determine if there are ones that would be better absorbed in one population versus another. So I skipped ahead, I skipped over oxybutynin, and I'm going to come back to oxybutynin in just a second. I'm going to go back also to naproxen. So we have naproxen here, 500 milligrams once daily is needed for headache. And then if you go down to the bottom of the list, you also see the patient has ibuprofen, 200 milligrams every 4 to 6 hours is needed for headache. So she actually has 2 medications on her medication profile that are NSAIDs that are basically the same type of medication. If she were using these together, she would be taking 2 of the same class of medications. And we also know that NSAIDs and hypertension have a drug disease state interaction. And so she definitely shouldn't be using 2 agents in the same class. And these agents, naproxen and ibuprofen, are also on the Beers list for an increased risk of GI bleeding in patients who are over 75 years old. And even though she's on a proton pump inhibitor, it doesn't eliminate that risk. And so we would still recommend that she not use naproxen or ibuprofen based on the Beers criteria, the drug disease state interaction, and the availability of alternative medication. So for this patient, Tylenol would certainly be safer for the use of headaches as compared to ibuprofen or naproxen. The next one on our list we come to is oxybutynin. Oxybutynin ER, 10 milligrams by mouth once daily. So oxybutynin, at first glance, you might look at it and think the patient has incontinence, so oxybutynin, that seems correct. But oxybutynin is not indicated for stress incontinence. And so if you fail to recognize the incorrect indication, a prescribing cascade could ensue. So it's likely this patient is experiencing dry mouth due to the oxybutynin use, but she shouldn't really be on the oxybutynin in the first place. So if we eliminate the oxybutynin, that will hopefully resolve the dry mouth, and we won't have to recommend anything for the patient to use to improve dry mouth. Oxybutynin is also on the Beers criteria. It is recommended to avoid if possible, and if not possible, because it has such strong anticholinergic effects, we would want to minimize any use of anticholinergic medications or the number of anticholinergic medications. It is has been implicated, or there's a risk of cognitive decline. So we would recommend discontinuation of that And there are other options that can be used for stress incontinence, and physical therapy can be a great non-medication related recommendation for stress incontinence. The next medication I'll come to is the aspirin, 81 milligrams daily. For a while, it seems like everybody was recommended to take aspirin, and it wasn't uncommon to see aspirin on a profile. And even now, there are a lot of patients for whom an aspirin a day may be appropriate, but there are a lot of patients for whom an aspirin a day is not appropriate. And it's readily available over the counter. People may make a choice on their own without you even telling them to choose to take an aspirin every day. So I think that, thank you, Lori. Sorry, I just saw your comment. Thank you for chiming in. Yes. So I think we sometimes think that the way to solve problems that our patients have, if there's a medication or a possible medication, is to use that first, but there are other ways that can be more effective for our patients. And so I think physical therapy is a great example in this case. As far as aspirin goes, though, it is a drug to be used with caution in the 2019 Beers criteria. We see that this is even recommended in the standards for diabetes care. So you may think, well, she has diabetes, so she should still probably take it. But for patients over the age of 70, standards in diabetes care says specifically, for patients over the age of 70 years, with or without diabetes, the balance appears to have greater risk than benefit when discussing the use of aspirin versus aspirin 81 milligrams versus no aspirin. And so there has been a recognition of the increased risk of bleeding in patients with aspirin as they get older, that risk benefit changes and shifts. So if a patient is older and they're on aspirin for primary prevention only, that's a really good indication to stop and pause and say, do we really need this medication? Even if it's over the counter, do we really need this for this patient? And it can be more harmful for them to take it. So again, it's on the Beers criteria list to be used with caution. It's not recommended for patients who are older. And we would fully support that, I guess, looking at this. So I would recommend discontinuing that. And then finally, omeprazole is the last one on our list, 20 milligrams daily. I'm not really sure why this patient is taking omeprazole. Maybe you aren't sure either, but that's a good indication for us to pause and to say, why is this patient taking omeprazole? And maybe there's a reason we don't know of. Maybe it's not listed in the current medical history, but there is no indication that I could see based on the information that I have. I do know that omeprazole can decrease bone density. It can decrease gastric pH. And so, or I should say, it can increase gastric pH. By decreasing acid suppression. And there would be no real indication or recommendation for this patient to continue omeprazole. So that would be something that we could potentially recommend discontinuing. Oh, that's a lot to go through, right? All those medications. Hopefully you took away a couple of pearls from each of those medications as we were talking about them today. But overall, I think the impact of this is you look at this medication list and you might not think that there's a lot to take care of here. It looks pretty standard. These medications are maybe used fairly commonly, but overall, we recommended the discontinuation or reevaluation of 7 prescription and OTC medications. We recommended combining a product for antihypertensives with a dose decrease. We recommended decreasing the dose of atorvastatin to a moderate dose. We recommended using Tylenol. So the number of medications before the review were 13, and the number of medications that we have left after the review, 6. So we lost 7 medications. We lost over half of the medications, and not because they were bad necessarily, but they maybe weren't the right medications for this patient. That's a lot when you think about number of medications being taken in a day by an individual, and polypharmacy, and thinking about preventing adverse drug reactions. That's saving money for the patient. That's saving frustration, or saving having to swallow all those tablets every day. So it is very helpful for us to be able to stop and pause and look at the medications with a more critical eye as we're reviewing patients and their prescriptions that they're on, and determining as they begin to age if they all still remain appropriate. again, these are medications this patient may have been on for years and years, and they may have just continued to follow her. Maybe she's not having an adverse drug reaction yet, but our goal is to prevent those if we can. So stopping, pausing, and looking for those opportunities for us to improve our patients' care through the review of their medications is something that your pharmacist would love to help.
A question: do outpatient pharmacists make recommendations to providers when a patient is filling meds, or is this mostly inpatient where you have access to labs and clinical data?
I think that's a great question, Katie. I think that there are some outpatient pharmacists that actually do have some access to lab data, and then some outpatient pharmacists that are also doing medication therapy management reviews for patients. And so those pharmacists would be looking collectively at the patient's medications. They may not have labs to be able to make specific recommendations, but they may be able to give you a recommendation that says, review this patient's renal function, consider if a dose adjustment would be appropriate. So they can clue you into things even if they don't have access to those labs specifically. And then if we have a patient that we think maybe taking too many meds, who should we recommend they consult with to review meds, doctor or pharmacist? I think that's a great question as well. It would be best if they could work together with both their doctor and their pharmacist to review their medications. So in some cases, pharmacists don't have access to all the information. Even when I started, it's important for me to know goals, because I can make better recommendations if I know what the goal of therapy is for someone. So if I'm working in a clinic setting, that's sometimes easier to see than not, but we can make general recommendations. And certainly a pharmacist can review the medications that a patient's taking to look for duplicates and that type of quick catch, if you will. And a lot of times those things are happening at the pharmacist level. One thing to do to really encourage your patients, one thing to do to help pharmacists catch those duplications or to catch interactions and potential problems is to suggest that your patient fill their prescriptions at one pharmacy. So if a patient is getting prescriptions filled at CVS and then at an independent pharmacy, those computer systems may not be talking, won't be talking. They won't know if they're getting one antihypertensive filled here and an antibiotic filled here if there's a drug interaction. So it's always good for your patients to have a list of their medications. If they're using a pharmacy that's not their normal pharmacy, to share that list with the pharmacist that's filling their prescription, to do some of those checks. But if they can, to always have their prescriptions filled at the same pharmacy. That allows them to check every time something new is added.